Thank you very much, Sabine, and thank you for the invitation to be part of this exciting webinar series. Today, the title of the webinar, the seminar, Digital Health and Artificial Intelligence, a Cure or a Curse for Health Equity. And before I go into who I am and what we'll be talking about today, the reason for the title actually is because in the research field, we see two different trains of thoughts. On the one hand, digital health and AI is positioned as this great equalizer. There's a great bunch of literature around what are the equity benefits of digital health and AI. It doesn't have the human biases, but there's an equivalent amount of literature that says, well, it actually exacerbates all of these inequalities. So today I want to spend a bunch of time kind of disentangling the question, is digital health and AI a cure or a curse for health equity? Now, then the first question is, who's talking? Well, my name is Robin van Kessel. I am the Hoffman Fellow between the London School of Economics and the World Economic Forum. I am also the co-founder and co-director of the AI and Digital Unit at LSE Health, and I'm still proudly an assistant professor at Maastricht University with a PhD in comparative health policy. Day in, day out, my research portfolio focuses predominantly on the intersection of digital health and AI technologies with health systems and policy and health inequalities. Now, before we go deep dive, let's spend 2 to 3 minutes making sure that all of the noses are in the same direction, as we would say in the Netherlands. The social determinants of health is a construct that has been devised since about the 1990s. And at the time, it was absolutely revolutionary. It recognized the importance of social influences on health outcomes, such as education, work environment, employment, water and sanitation, housing, and implied that our health went far beyond what happens within the walls of the hospital or the walls of the GP. This initial framework back in 1991 broadly referred to political and economic environments, yet did not really go into detail as to what those might look like, which paved the way for a lot of exciting work that happens afterwards, specifically catered around the political and commercial determinants of health. The framework for commercial determinants, albeit probably not entirely readable on this slide, is depicted below, and the reference by Gilmore in 2023 in The Lancet is provided on the slide. I do highly recommend you have a look at that. It's a very exciting read. Then came the digital era. 2020 came around, COVID hit, and the entirety of our health system suddenly had to be digital. Then 2022 came around, ChatGPT was released, and here we are today, the information era in full bloom. So a new and complementary framework on top of the social, commercial, and political determinants was needed, namely the digital determinants of health. And I took it upon myself and about 56 others to devise that framework. And basically, we started to look at not only what novel determinants were in place, what novel determinants emerged, but also which ones of the social, political, and commercial and economic determinants changed. Certain expressions, certain determinants suddenly had different expressions. Think about how our work-life balance or how our working environment has changed as a result of digital technologies. Think of how political campaigning has changed as a result of digital technologies. And I think one of the most poignant points that we try to communicate in this piece of work was that these technologies are not siloed. It's not you have a set of social determinants, you have a set of political determinants, and they kind of do their own thing and they never engage. Now, they realistically form one big broad spectrum that we artificially divided in 4 categories because we like putting things in boxes to make them understandable. But realistically, it's a big, complicated web, almost like a neural network, but a big, complicated web that kind of intermingles and interrelates to one another. To make sense of them, we've split them across the 4 dimensions: social, political, commercial, and digital, and layer them across 5 kind of ascending layers of society: person-specific determinants, community determinants, technology-related determinants, policy determinants, and political, economic, social, and cultural determinants. There might be a 6th societal category in a follow-up piece, namely environmental determinants, but that fell outside of the scope of the study at the time. Right. Again, I cannot emphasize how important it is to realize that, the political determinants affect policy determinants, but affect technology determinants, affect community determinants, and affect person-specific determinants. But inversely, that also works. The way that person-specific determinants, that certain population groups engage with digital technologies can highly affect how policy is shaped. If in a quickly aging society, certain decisions surrounding digital determinants may look very different than in a society that is younger. Now, the role of artificial intelligence across all of these um, determinants is a pervasive one, is a complex one. It's not necessarily a bad one, but it can be a bad one. And that sounds chaotic, and that is because it is. So in political determinants, I already alluded to the fact that artificial intelligence technologies these days have a major effect on election campaigns. Think of the 2024 election in the United States. Think of the previous elections, forget the year they were in here in Britain. Myself and Sabine were from the Netherlands. And there too, social media and the AI technologies that power social media made a profound impact on how elections were held, mainly because of the probability and the likelihood that people are served with content they want to see, not necessarily balanced content. In terms of political determinants, they can also affect government decision making, again, for the very same reason. Politicians, regulators, everyone at the decision-making level effectively is affected by the information that is presented to them. And with the increasing role of AI, that is more reinforcing than it is broadly balanced in terms of its information provision, that government decision-making can be entirely skewed by AI technologies. Now, moving into the commercial and economic determinants, we can look at personalizing marketing strategies. Just last night, I attended a book launch by a dear colleague of mine at the London School of Economics that talked about how the internet has hijacked our health, and how, as part of the book launch, a poignant point that came up time and time again was, for instance, supplements, and how unregulated those are, but how marketing strategies on social media, I think Instagram, TikTok, are preying on the unregulated nature of the product, as well as the desire for people with certain health and wellness complaints to improve and to get better. Now, that's not to say that AI is necessarily a net negative for personalized marketing strategies, because the inverse can also be true. Think of vaccine strategies, think of health promotion campaigns that can be empowered through AI by reaching people that are likely benefited from those campaigns. And finally, the digital determinants of health. And this is, I suppose, where the biggest paradox comes in, because the first 2 points, it can create and spread misinformation, absolutely. But equally, it can create and maintain the spread of accessible health information. And then the barrier between what is misinformation, disinformation, malinformation, and what is accessible health information that eventually may become outdated becomes very thin. AI also has the negative capacity to maintain and expand digital divides, but also has the ability to facilitate novel care pathways that may allow the expansion of care coverage. So realistically, AI is not a net negative or a net positive. It is entirely dependent on the context within which it is deployed and the type of AI that it is deployed within that context. Ultimately, it comes back to the title of this presentation. Is it a cure or a curse? Well, in order to get a better handle on that question, we have to ask ourselves two questions. First of all, who has internet access? And we can look at some data from Eurostat from before COVID to get an idea. Again, these numbers will probably look slightly different today as society has moved further into the information era. But for illustration, this is a microcosm of what is still very much prevalent in the broader world beyond Europe. And what we saw using data from 2019 was that there was a large discrepancy within the European region alone in both the rate at which people could access the internet, with Southeastern Europe averaging around 75% of people being able to access the internet, and the northwestern parts of Europe being able, or 98% of people being able to access the internet, as well as the cost of internet, where the same broadband package costs vastly different prices in the northwest, northeast, southwest, and southeast of Europe, which points in Europe alone to a major northwest and southeast divide, let alone what the broader ramifications are if this data were to be extrapolated beyond Europe to, let's say, North America, South America, Southeast Asia. So at the very baseline level of can people even access the internet, let alone digital or AI technologies, there's already a layer of inequality, a layer of discrepancy arising. Now, when we dive into these European states, we see that people in urban communities, on average, have higher internet access rates than those in rural communities. So there's not even like across Europe, there is a northwest southeast divide, but then within countries, there's an urban rural divide. And moving further into that, there is an income divide where people with higher levels of income tend to enjoy higher levels of internet access than those with lower incomes. Will people with higher incomes typically live in urban environments? Yes. Is there a slight degree of bias or a slight degree of confounding across some of these factors? Sure, I accept that, but this is why this is an exploratory study, not an inference. Which one of these factors is most leading? We actually don't know. What came first, the chicken and the egg in that sense? But then the second question comes along. Who is the skill? So accessing the internet is nice, it's great, but do people then actually have the skills to navigate the internet and to navigate these digital environments in any way that is meaningful to them? Well, what we saw is that on average, people with higher education levels tend to enjoy higher levels or better developed digital skills than those with medium or low levels of education. When I say high, medium, and low levels of education, these are self-reported categories by Eurostat. But then the question becomes, the subsequent question is, well, there's clearly a demographic discrepancy across Europe, within European states, even within populations, within countries. But is that all it counts? Is it the case if you end up in the wrong demographic group, is that it? Well, not really, because there are a lot of factors that affect the implementation, the uptake, and the utilization of digital health and AI technologies that exceed and go beyond, for example, health innovations such as pharmaceuticals and medical devices experience adoption primarily through payment policies after proof of clinical efficacy. Yes, there needs to be a positive perception from users and prescribers for digital health and AI technologies, especially those that require active engagement after prescription. However, on the one hand, we have the socio-demographics that dictate, by and large, whether someone has access to the internet and whether someone is put in the position to be able to access these digital health and AI technologies. There's also the policy component and the technological component that are equally important to whether some of these technologies are actually used and therefore can bring their benefit and their harm. And we did, a couple of years ago at the LSE, we did a deep dive into, well, what are these implementation factors specifically for digital therapeutics? This was right before AI took off the way that it did. We did find that a lot of the factors that we found for digital therapeutics were also applicable to AI technologies more general. And we found generally four broad key players, key players that affected the implementation of AI technologies and digital therapeutics, which looked something like this: very chaotic, very kind of sensory intense framework that does point you in the direction of, well, what do we consider important? And in the bottom right, you see the individual domain. This is where your patients are. And you'll see under the characteristics, age, income level, living conditions, education level, the parts that we just talked about. We have a digital health competence, which is whether someone has sufficient levels of internet access, whether they have the digital literacy and skills, whether they have sufficient levels of risk perception, whether they have health literacy. This is the part that I spent the first section of this presentation talking about. But then comes the rest. Then comes, are the systems in place? Do we have institutions that are able to assess the quality and the risk profiles of the new technologies? And then we have the technologies on their own. And I suppose in the next half of the presentation, I want to talk a lot more about the technologies themselves, because we can talk about the responsibilities and people needing to have sufficient level of digital literacy. That's great. But ultimately, we can't put all of the responsibilities on the individuals. And it's also a critical point that we understand what the technologies are that are facing us, and more importantly, what they're not. And there, I do want to zoom in on AI specifically, because if we talk about digital technologies, that can mean anything from an electronic health record to the most complicated agentic AI system. And there's a heterogeneity in that field that I can't capture within the next 20 minutes. So to kind of really bring the point home, let's focus on the microcosm of AI and what does AI in health do and what could it do? And for that, I made two fairly, well, I wouldn't call them exhaustive, but I collected a number of use cases for AI in health and healthcare, where on the one hand, what it already does today is recognize pathology in medical imaging, identify risk profiles, predict hospital readmissions, identify medical compounds, and support drug prescriptions through clinical decision support systems. What we hear about is that it can automate administrative and documentation tasks. It can simplify medical jargon. It can routinely collect patient information asynchronously ahead of a doctor-patient consultation. It can support note-taking during those very consultations, and it could theoretically improve patient health literacy. Now, what's interesting is that the AI, both of these titles say what does and what could AI do. They're fundamentally different AI systems that are used on the left side or on the right side of this slide. And that is exemplified by the fact that image recognition AI, the evidence bases on the benefits and their performance in the healthcare system is quite rich. It's been ongoing for 10 to 30 years. Radiology has never looked the same after AI entered the field. On the right side, a lot of that stuff is to do with foundation models, large language models. And the evidence there is emerging. It's only been going between 0 and 5 years. I mean, the first launch of ChatGPT is not even 5 years old at this point. So the right side, very nascent. Left side, we've come to terms with the fact that AI can do a lot of good things already and is already doing a lot of good things in our health systems. But AI technologies have flaws, and sometimes those are significant. And for example, if we zoom in on generative AI, particular subsection of AI technologies, hallucinations can happen. And that is kind of a fact of life in generative AI. I mean, the CEO of OpenAI recently admitted as such. Generative AI will hallucinate. That's just part of how the technology works. The similar way that we might misremember things is that opens up the can of worms of whether cognitive processes of humans are equivalent to the prediction of AI, but let's not get into that today. Well, these hallucinations are whimsical and presumably harmless sometimes, unless you need to pass a geography test. However, other flaws of AI are less whimsical, namely when a therapy chatbot results in the death of a person or an AI-powered coding tool wipes out an entire database. I imagine that happening in a hospital setting. You wake up, you get into work as a doctor, and suddenly all of your patient data is gone. Those are not insignificant flaws. And this is why regulatory systems are so important. Now, those are two fairly extreme examples. And to kind of provide nuance to that, we at the LSE were interested in whether AI is an exacerbator or an equalizer. So we created two fictional case studies, two fictional patients, one for hypercholesteremia, one for type 2 diabetes. Both we assigned varying demographic details. We had biological sex, either undefined male or female. We assigned ethnicity, either undefined white or black, or geographic location, undefined in the United States or in the United Kingdom. And that resulted in 27 vignettes for each for the disease categories with identical medical information, with the question of, well, can commercial grade LLMs consistently predict clinical guidelines that pertain to the case study? And the results, I can't show you the full results yet, given that these are still under review, but the results that we found that I can share is that we found that there was a big difference between diseases. And when I say big difference, it's at least a 15 to 20 percentage point difference between the ability of these large language models to cite type 2 diabetes guidelines than they are to hypercholesteremia guidelines. There's a big difference between countries, with, again, about 15 to 20 percentage point differences between USA guidelines being cited than UK guidelines being cited for hypercholesteremia. For type 2 diabetes, the difference is about 70 percentage points. And then the question is, well, why did that happen? Well, our best estimates were that the USA does not have separate guidelines for type 2 and type 1 diabetes. The UK does, and a large language model is not able to distinguish between that. So the very way in which clinical guidelines are produced within a country can be a political determinant merging with a digital determinant on whether these technologies are capable of citing clinical guidelines that inform care decisions more consistently. And most critically, for the purpose of this presentation at the very least, is that biological sex and ethnicity had barely any effect. So long as the medical information was correct, they could point towards guidelines roughly equivalent in equivalent fashions. The location of the patient was far more important, and the disease itself was important. Sociodemographics barely had any effect. So hypothetically, if that were to be extrapolated, an LLM could be seen as an equalizer, not necessarily an exacerbator of care quality. Of course, this was only two cases that we ran again and again and again for about 12,000 diagnostic LLM outputs. So this is very much preliminary data and needs to be done at grander scale, which I'm happy to say we will be doing over the next few months at a grander scale at the LSE. And I hope that I can share more of that in about 6 months' time. Anyway, to kind of look at the broader picture beyond our little microcosm of a study that we did is, well, how is fairness, how is equity actually measured? And the evidence on equity remains fairly scarce. A review of nearly 500 articles on AI fairness found that there was, when fairness is assessed, a major emphasis on ethnicity, sex, and age. It also found that there is a major reliance on tabular and image data, and very little on textual signal, audio, or video data. And that there is a major focus on group fairness and little to no on individual or distributional fairness. And within that group fairness, most of the focus is on, well, is the performance, is the fairness parity based or performance based? And that the definitions are shown on the right side. And I'm very happy. Well, the link to this particular paper is seen at the bottom of this slide. Some key takeaways. I cannot stress enough how wide a range digital health and AI covers in terms of what technologies are classified as digital health and AI technologies, with varying complexities. AI technologies will find in the most day-to-day use cases, such as Netflix and Google, to the most complex of medical devices. The versatility of the framing of the terminology allows for many use cases in the health sector, but a lot of those use cases remain nascent, especially with the newer generation of AI technologies. AI is able to escalate existing human and data biases, and there is a rich literature base that shows especially initial the initial wave of AI technologies suffering from data biases, as well as some, I suppose, some recent technologies also do that, especially, but that is then confined to certain medical practices. Think, for example, from skin cancer, where ethnicity suddenly becomes a much more important role. The evidence on health equity is nascent, even for those even for the AI and digital technologies that we consider early days. The reason why that is nascent and why that is not consistently measured is, quite frankly, part of it is a regulatory problem. FDA, NICE, regulators do not explicitly require, are increasingly requiring now, but for the longest time did not require an assessment of health equity. And the most poignant example of that is the fact that up until the 1980s and the 1990s, clinical trials were not required to disaggregate between men and women, resulting in profound differences in the way that we understand health and disease across biological sex. Luckily, that gap is slowly being filled, but we still have a ways to go, and especially in the context of AI technologies, we still have a ways to go. Finally, the key takeaway is that there exists this paradoxical harm protection association between social determinants and digital and AI technologies, where some of these AI and digital technologies in the health space can be really powerful. And if they're given to patients, they can make they can bring significant benefits to that patient. However, at the same time, if a patient is capable of using those digital health and AI technologies, they're also in a position where they can be negatively affected by the broader social determinants of health, digital determinants of health, and the digital and AI technologies that facilitate those negative impacts. Someone who is not able or is not willing or is not in a position to access Instagram or TikTok is going to be exposed to less misinformation, but may not be able to use some of the novel technologies. And that's not a zero-sum game. That's an individual determination per person to see which treatment and which what is the risks and benefits of bringing these new technologies into the world and into health systems and into society more broadly. We can't have one without the other, but I think and I suppose that is the core takeaway of this presentation. Is it a cure or a curse? Well, digital health and digital and AI technologies are both. They are both a cure and an innovator and a curse to public health in many ways. It's just a matter of how we as a society accept that these technologies are being distributed and used within healthcare systems and beyond them. Thank you very much. That would be my presentation for the day.